Morning, everyone. Okay, let's start our topic for today, opportunistic mycosis. Can you hear me?
Yes, sir.
Yes, sir.
Okay, then. So, what is opportunistic mycosis? This opportunistic mycosis is caused by fungi, which these fungi are normally present in human body as part of their normal flora. Like in healthy individuals, they never cause disease, and then they can also found in nature and frequently isolated as laboratory contaminants. Like they have no clinical significance. They don't cause any disease normally in healthy individuals, but when in some kind of conditions like low immunity, if a patient is suffering from diseases like HIV/AIDS, or if he's under some medication, immunosuppressive therapy like steroids or cancer therapeutics and all, this infection can cause certain diseases which may be harmful or may be fatal to that person. Do you get it?
Yes, sir.
Okay.
Yes, sir.
Okay, what are these diseases, opportunistic mycosis? So first of all is candidiasis. Candidiasis is a disease which is caused by a yeast-like fungus that produces pseudohyphae. This yeast-like fungus is called Candida, like a species called Candida. There are different species of Candida. We have Candida albicans and other Candida species. Candida albicans is the most common, and like it causes most of the diseases among this genus Candida. Okay, and then other Candida species which can occasionally cause infection, such as we have Candida tropicalis, Candida glabrata, Candida krusei, Candida parapsilosis, Candida dublinensis, Candida kaffir, Gulielmondi, and Vishwanathi. Okay, so this Candida can be found all around the world. Like is Candida albicans is the most common fungal infection, and there are some risk factors or predisposing factors like some people are prone to get infected with Candida albicans specifically. Like if you are in extreme of ages, like suppose newborn baby or old age or pregnancy, these physiological state they have low immunity. And sometimes like if you are under some immunosuppressive drugs, steroids, or after you get your transplantation, like renal transplant, heart transplant and all, you will bound to get some immunosuppressive drugs, and it will make that patient prone to get this candida infection. So malignant, same thing, it happens with malignancy also, because these people, they used to get cytotoxic drugs and all, which will lower down the immune status of the patient and HIV infected people. So sometimes antibiotics also, antibiotics, they will inhibit the growth of some bacteria and all, but instead they will favor the growth of fungus. So other conditions which lower the immune system, like immune status of the individual, like diabetes mellitus, febrile neutropenia. Neutropenia is a like abnormal low count neutrophils, and some minerals deficiency like zinc or iron also will predispose to candida infection. Do you understand?
Yes,
Yes,
sir.
sir.
Okay. So what are the virulence factors, like the factors which are present in this candida which can cause disease? Like Candida causes these factors like adhesins, which help in binding to the tissues, to the human human cells. So enzymes, we have aspartyl proteinases and serine proteinases, which help in invading the tissue. Uh, and then toxins, some toxins like glycoprotein extracts of Candida cell wall. These are pyrogenic. Like these glycoprotein extracts from Candida cell wall, they can cause fever. And pseudohyphae is like some growth present in fungi. Like they can, if you can see pseudohyphae in a clinical sample, you can indicate like you can say like that the infection is active, like the organism is multiplying. And phenotypic switching, like these some fungi, they can transform different phenotypic forms in the tissue, like yeast, they are something round in structure. Pseudohyphae is like, there's one picture in the back, I'll show you. Yeah, yeast are something like this, round in structure. And then pseudohyphae, these walls are not parallel to each other. And then there is constriction, septate are constricted. But hyphae, true hyphae is this, these walls are parallel to each other, and the these septa are not constricted. Okay, do you get it?
Yes, sir.
Yes, sir.
Yes, sir.
Okay, so what kind of diseases these candida? So like it can cause mucosal candidiasis, like it can affect the mucous membrane of various organ of the body, like oropharyngeal, the mouth and the pharynx. It can cause wide adherent painless patch. This one is that oropharyngeal candidiasis, that wide adherent painless patch. If you're trying to scrape it out, it is very difficult to scrape, otherwise it will cause bleeding. And then another one is vulvovaginitis, like it can cause pruritus, pain and vaginal discharge, like whitish curd like in severe cases. And it can cause balanitis and balanophosphitis, inflammation of the gland penis. And then esophageal candidiasis, esophagus also, it can cause similar type of lesion like this one, which is caused in the mouth, but it happens in the esophagus. Okay, you got now?
Yes, sir.
Okay, and then after that we got this one, chronic mucocutaneous candidiasis. Like it mainly affects infant and children with low cell-mediated immunity. In the human body, there are mainly two types of immunity. One is cell-mediated immunity, which involves the T cells, and the humoral immune response, which involves the antibody production. So infants and children with deficient CMI are prone to chronic mucocutaneous candidiasis. So they will produce lesions on hair, nail, skin and mucous membrane. And if you're trying to treat these kind of patients, it's very difficult to treat because these fungus are resistant to these antifungal drugs. So you can have cutaneous candidiasis. Cutaneous means anything that involves the skin. So which part of the skin we can have intertrigo, which can produce erythema and pustules in the skin folds, associated with tight fitting undergarments and sweating. Like anything like you're wearing clothes, like if a patient is wearing clothes, tight fitting clothes and all, undergarments, and then associated with sweating due to high humidity and all, no, then the patient are prone to get these cutaneous candidiasis particularly in the skin folds. Which erythema, which is characterized by erythema, redness of that skin and pustules. Sometimes it become like abscess formation, but it's filled with clear fluid. So sometimes it affects the nails also, like paronychia and onychomycosis. See the nail of these patients, this is onychomycosis. And then diaper candidiasis, sometimes in newborn babies with diapers and all, there'll be candida infection, we used to call diaper rash. So it's mainly caused by candida species. And then perianal, around the anal region, candidiasis also can occur. Eroso-endodigitalis blastomycetica. This one, it will affect the web space between the fingers, the two toes and all. And then sometimes it will affect the whole body, the whole the whole system of the body, like generalized disseminated cutaneous candidiasis. It will spread throughout the whole body, throughout the skin of the whole body. Okay, do you get it?
Yes, sir.
And then after cutaneous, after it affect the skin, it will become invasive. Like invasive, it will affect the internal organs through hematogenous or local spread. Sometimes through the skin, it will spread to the adjacent organ, or through the bloodstream, it will affect the distant organ in the body. Like it can cause urinary tract infection, pulmonary candidiasis or septicemia, like candida infection of the lungs, and sometimes septicemia, bloodstream infection caused by candida species, sometimes arthritis, infection of the knee joint, osteomyelitis of the knee, of the arthritis, infection of the joints, bone joints, and sometimes of the bone, meningitis, infection of the meninges, ocular, of the eye, keratoconjunctivitis. We have like fungal keratoconjunctivitis. It will affect the cornea and the conjunctiva, and endophthalmitis. It will affect the this one the anterior chamber and posterior chamber of the eye. And then sometimes hepatosplenic candidiasis will occur, like infection of the spleen and the liver, and then it will affect the whole system of the body also, which we call disseminated candidiasis. Sometimes, like in the hospital environment, like a patient may get infected with candida species, mainly by candida glabrata. So you have to remember that candida glabrata is the most common cause of nosocomial candidiasis. Okay, you get it?
Yes, sir. Yes, sir.
Okay. Sometimes it can cause allergic manifestation like candidate. It's an allergic reaction to metabolites of candida. Like sometimes the like due to some immune response, it will cause some allergy-like manifestations. Like it will cause like vesicular lesions in the web space of the hands and other areas, and similar dermatophytid reaction. And then other allergic reactions like will include gastritis, like irritation of the stomach, irritable bowel syndrome, and eczema. So how to diagnose this one? So like first of all, we have to collect the specimen. Like suppose if that mucus patch from the oropharyngeal mucosa, we can collect that one, or from the skin and from the nail scrapings, or sometimes if there was invasive candidiasis, from the sputum, depend on the clinical manifestation of the patient, like urine or blood. And first of all, if you want to see this candida, we have to do gram stain. Gram stain will show like gram-positive oval budding yeast cells with pseudohyphae. See, these are gram stain. They appear as gram-positive, but their size is much larger than cocci. So you can see the budding here. Everyone can see or what this picture?
Yes, sir.
Yeah, see this budding.
Yes, sir.
This one is budding out from the parent cell. Okay. And then sometimes pseudohyphae are there. See, this one is pseudohyphae. You got it now? This one hyphae, that tubular-like structure. These are not hyphae. These are pseudohyphae. Okay? You got now?
Yes, sir.
This is gram-positive, oval, budding, sometimes with pseudohyphae, like this one. Okay? So if you want to culture, you can use this subrod dextrose agar. Sometimes with antibiotic supplements, we culture at 37 degrees Celsius. Why we are using antibiotic supplements is that these antibiotic supplements will inhibit the growth of other bacteria, of other normal flora bacteria present, which will inhibit this candida to grow in the SDA, subrod dextrose agar. So we use this antibiotic supplements. So we can also grow in bacteriological culture media like blood agar or blood culture bottles, which conventional or automated one. And then they produce these colonies creamy white, smooth and pasty with typical yeasty odor. This type of colonies they will produce creamy white, pasty, smooth, and then that odor is their typical yeasty odor. Okay, you see this picture, everyone?
Yes,
Yes,
sir.
sir.
Okay, so we can do this germ tube test also. See germ tube now, like this test we can differentiate between Candida albicans and other Candida species. So this germ tube test is done. We used to do it routinely in our lab. This germ tube test is also called Reynolds Broad phenomenon. See, and then these germ tubes are long tube-like projections extending from the yeast cells, differentiate from pseudohyphae as there is no constriction at the origin. See this germ tube, you can see these budding yeast cells, they produce germ tubes. So if you're doing germ tube test, if these germ tubes are present while examining that wet mount of fungal culture, if these germ tubes are present, then we can say this test is specific for Candida albicans. I told you before, there are many species of Candida. Candida glabrata is there, cruzi is there, and then lots and lots are there. But we want to see if this Candida is especially Candida albicans or not, so we can do this germ tube test. Okay. Then another method of identifying Candida albicans is this one, dull plate culture. We can do it in a cornmeal agar. So Candida albicans, they produce a thick wall chlamydospores. These thick wall chlamydospores we can see this thick wall chlamydospores. These are Candida albicans if we are culturing it in cornmeal agar. And then chrome agar, we can do this one chrome agar, like different Candida species produce different color colonies. This one is specific for Candida albicans. The other one, this one might be cruzi, and the other different Candida species will produce different color. So like this one, Candida albicans will produce this greenish blue color. So the other, like cruzi, will produce this brown to black color, like that. Okay. So we can use other other species identification method, like this one, if we can see growth at 45 degrees Celsius, like Candida albicans usually grow at 45 degrees Celsius, but dublinensis does not grow at 45 degrees Celsius. And then other tests, we have carbohydrate fermentation tests, carbohydrate assimilation tests, and other molecular methods. So we can do immunodiagnosis like antibody detection, like ELISA latex agglutination tests, which detect antibodies against the cell wall Menin antigen, and then antigen detection like this. We can do ELISA, which detect the antigens against cell wall Menin and cytoplasmic antigens. So we can do enzyme detection also, like enolase, aspartate proteinase, and other tests for metabolites like mannitol, arabinitol, and then G-test is also confident for detection of B13 D-glucan. So how will you treat candidiasis? Like topical azole, we have lots of ointments like ketoconazole is there. It's available in market, like cutaneous cases, oral thrush and all. We can use this one topical ointment and all. And then for this one, esophageal and vaginal candidiasis, we can use oral fluconazole or caspofungin. And for disseminated candidiasis, we can use liposomal amphotericin B or caspofungin. And Candida glabrata and Candida cruzi exhibit intrinsic resistance to azoles. So like for other species of Candida, we can use azole, like this fluconazole and all. But we have to make sure that for Candida glabrata and Candida cruzi, we cannot give azoles because they are intrinsically resistant to azoles. Okay, do you get it, everyone?
Yes, sir.
Okay.
Sir.
Yes, sir.
Okay, that's all for candidiasis. Then we'll come for another opportunistic mycosis, which can cause infection in immunosuppressive individuals. That one is cryptococcus. With cryptococcus is caused by this organism, Cryptococcus neoformans. Mainly, there are two species of Cryptococcus neoformans. One is Cryptococcus neoformans, and the other is Cryptococcus gattii. And there are 4 serotypes, A, B, C, and D. 2 varieties like Cryptococcus neoformans var. grubi, and this Cryptococcus neoformans has 2 varieties, variety grubi and variety neoformans. So like how will you get infected by Cryptococcus? Like mainly by inhalation of aerosolized forms. In immunocompetent individuals, like individual with good immune status and all, defense mechanism in the present the body will limit the infection by Cryptococcus. However, patients with low immune status, they will get pulmonary infection, which is followed by dissemination throughout the bloodstream. Sometimes this Cryptococcus can cross the blood-brain barrier, and they migrate directly across the endothelium or carried inside the macrophages as Trojan horse. I hope every one of you know about the story of Trojan horse, nah?
No, sir.
Yes, sir.
Do you know about this one? Okay, like once they get disseminated throughout the bloodstream, nah, they will cross the blood-brain barrier. This blood-brain barrier, they protects the brain from the rest of the body. Okay, so like Cryptococcus, they migrate through that blood. This blood-brain barrier is made of endothelial cells of different cerebral vessels. So they migrate through this endothelium or get carried inside the macrophages as Trojan horse. So once they reach the brain, they will cause infection of the meninges, causing meningitis and encephalitis and all. Okay, so these Cryptococcus, they have polysaccharide capsule, and this polysaccharide capsule, they have a capsule around them, like it is antiphagocytic and also inhibit the host local immune response. Like this capsule, they protect the this Cryptococcus from being phagocytosed by the phagocytic cells. And like local immune response also, they cannot kill this Cryptococcus because of this polysaccharide capsule. Okay, and then they have the ability to make melanin by enzyme phenyl oxidase, and other enzymes which are present, which these Cryptococcus possess, are phospholipase and urease. Okay, risk factors. Who are the patient more prone to get this infection? Like sometimes patient with low immune status, particularly with advanced HIV infection. If you see the CD4 T cell count less than 200 per microliter, then there are more risks of getting cryptococcal infection. And sometimes patient with hematologic malignancies like leukemia and all. Okay, and then transplant recipients, like those patients who have received renal transplant, kidney transplant, heart transplant, liver transplant, and so on and so forth. And patients on immunosuppressive or steroid therapy, like some patients will get immunosuppressive or steroids and all, nah, they will be more prone to cryptococcal infection. And then we have another pulmonary cryptococcosis. Pulmonary cryptococcosis is the it's a most important manifestation of cryptococcosis. Like the patient will, like I told you, the infection will be transmitted through inhalation of aerosols. So first and the most common presentation is pulmonary cryptococcosis. Then meningitis, like I told you now, like that Trojan horse phenomenon, like they will get carried through macrophages or pass through the endothelial cells into the brain. So uh, they will cause infection like meningitis and all. Uh, and once a patient got meningitis, these are the common manifestation, whatever the cause is, whether it's bacterial or viral and all. Now, they will have headache, fever, sensory and memory loss. Like patient will be like he will not remember anything, and then cranial nerve paralysis. Sometimes they will have paralysis of cranial nerve, like loss of taste, and then sometimes they will have this one paralysis of the face and all. Loss of vision, loss of vision is mainly due to optic nerve involvement. Okay, they will also have skin lesions and bone lesion. Bone lesion is an osteolytic type, like they might get pathological fracture also. And then if you see this with regards to the geographical distribution, this Cryptococcus neoformans variety Gruby serotype A strains are found worldwide. And then compared to neoformans, which are restricted mainly to Europe. And Cryptococcus cathy is confined to tropical areas like India, Southeast Asia regions and all. So this Cryptococcus neoformans is found mainly in soil contaminated with avian excreta and pigeon droppings. Like all of you know about pigeons, huh? So those pigeon droppings and all are they might contain these Cryptococcus neoformans. So you have to be careful while playing with pigeons and all. Okay. Then how do we diagnose this cryptococcal infection. Depending upon the clinical manifestation, we will take the specimens like CSF if the patient is presenting with suspected meningitis, blood disseminated cryptococcal infection, or skin, sometimes cutaneous manifestation of cryptococcal infection. So how to detect? We have different detection methods. Like we have negative staining method, like we have this modified India ink and nigrosin stain, which demonstrate the capsule. This is India ink. Like negative is like the background will appear dark, and then this cryptococcus will appear bright. And then this one I told you that polysaccharide capsule is there, no? Which will inhibit phagocytosis, and then which will weed away this one what local inhibitory response and all. No? This is the capsule. Everyone can see this picture.
Yes, sir.
Okay, this is the
Yes,
capsule.
sir.
This is the capsule. Okay, when we perform this negative staining method. Okay, and then gram staining, they will appear as gram positive round budding yeast cells only. Okay, other method like we have muci carmine stain. It stains the carmine noophilic cell wall of the Cryptococcus neoformans. And Mason Fontana stain, it demonstrates the production of melanin. Alcyon blue stain demonstrates the sometimes capsular antigen detection from CSF or serum by latex agglutination test can also be done. So how do we culture? Like we can use SDA, but this time without antibiotics. Blood agar or chocolate agar, incubated at 37 degrees Celsius. And then sometimes blood inoculated in biphasic blood culture medium. Colonies will appear mucoid, creamy, white, and yeast-like. This one is mucoid, no? Mucoid, very moist, and then cream-like, no? And then yeast-like, okay? And then how do we confirm? We can use this agar, Niger seed agar and bird seed agar, and then they can grow at 37 degrees Celsius. Uris test is positive. Assimilation of inositol and nitrate and mouse. Sometimes we can test in mouse also. We can inoculate these cryptococcus into mouse, and then we see whether they produce any disease or not. Okay, how are we going to treat cryptococcal infection? Suppose the patient is not having CNS involvement and all, we can just give fluconazole. And then sometimes if because this disease is more prone in HIV infected patients with CNS involvement, we can give induction phase for 2 weeks. We can give amphotericin B, flucytosine, and then we can shift it after 2 weeks. We can shift to oral fluconazole therapy, and then we have to continue it till CD4 T cell count raises to more than 200 microliter for 6 months. Okay, you got it?
Yes, sir.
Yes, sir.
Okay. Next one is zygomycosis. This is a life-threatening infection which caused by an aseptate fungi belonging to phylum Zygomycota. You don't need to know about these things. So pathogenesis. These include some some species which can cause mucormycosis, and then others can also cause entomophthalomycosis. Have you heard about mucormycosis? Have you heard about
No, sir.
mucormycosis? No. Have you heard about that black fungus?
No, sir.
So black fungus
Yes,
is that
sir.
mucormycosis. Okay. See, these spores they can be found in the environment. Okay, like how do they get transmitted by mainly by inhalation, sometimes by inoculation or rarely ingestion of spores. Suppose these spores are growing in the environment, no? And then sometimes you get inoculated accidentally or ingestion of something like vegetables and all, no? If you don't wash them properly, then you can get this infection and all. So these spores now they develop into mycelia form, which are angioinvasive. Angioinvasive, they can penetrate the blood vessels. Okay, they can penetrate the blood vessels. So what are the predisposing factors? Like conditions with increased iron load. If a patient is having polycythemia, this polycythemia is a reverse of anemia. Anemia is low iron load, no? But polycythemia is with increased iron load. So increased iron load will increase the risk of developing mucormycosis. And then diabetic ketoacidosis. Diabetic ketoacidosis is a manifestation of diabetic mellitus. And stage renal disease, those patients with chronic kidney disease, which are in the end stage, terminal stage, they are more prone to get mucormycosis. And then those with iron therapy or deferoxamine, and then those patients with defect in phagocytic functions, like phagocytes cannot phagocytose these mucormycosis. Okay, how do they manifest? Like rhinocerebral mucormycosis, they form orbital cellulitis. See this orbital cellulitis. Proptosis is that bulging of the eyeball. See this one, this guy eyeball is bulging from what? And vision loss, like if your eyes is like this too, like you cannot see properly only. Okay, and then pulmonary mucormycosis in patients with leukemia, patients with blood malignancy, leukemia and all, pulmonary mucormycosis can be seen. And then cutaneous mucormycosis, and then gastrointestinal mucormycosis like necrotizing enterocolitis. And then sometimes it can affect the brain when it becomes disseminated. And sometimes we can see miscellaneous form also, which we cannot describe. Okay, then how do we diagnose this one? Like sometimes from the tissue, tissue biopsies, I suppose this guy is having this kind of lesion, we can take a biopsy from here, and then while examining it with some stains like methenamine silver stain, these broad accepted hyphae, hyaline hyphae with wide angle branching. See this one, this hyphae, you can see this hyphae, there's no septi, like that, like I've shown you earlier, I think. See this one is septa. Okay, septa, this hyphae, you can see septa, and then but here in case of mucormycosis, this one, this hyphae is very broad. Okay, see this broad, this diameter between these two walls is quite broad, and then you cannot see this septa here. Get it? You cannot see this septa, and then there's a branching of this hyphae, wide angle branching, like obtuse angle branching. Okay, so when we culture it on SDA, we can culture at 25 degrees Celsius. They produce that white cottony woolly colonies in tube filling with growth lid lifters. Sometimes why we call lid lifters, see that this one, if we grow in SDA, they looks like cotton woolly colonies, and then they fill the tube, and sometimes they fill the tube up to the lid. It's like this lid is coming up, lifting this lid, so we call lid lifters. In some species like Rhizopus, they have salt and pepper appearance. Maybe this one is salt and pepper appearance, and this one like black colony, and then some white colony like salt and pepper, and this one is cottony woolly colonies. Okay, do you get that?
Yes, sir.
And then
Yes,
sometimes
sir.
from the colonies we can do LPCB mount. LPCB is lactophenol cotton blue mount, and then we can do this staining, and then broad accepted hyaline hyphae. You can see this broad hyaline hyphae. There's no septa here. Okay, and then they have this sporangium here, and then they contain this sporangium. They contain so many sporangiospores. Okay, and sometimes these rhizoids can be found like root-like growth arising from hyphae. These rhizoid are there, okay. These fungi and all, they looks like plants. Okay, see, like imagine if plants are growing inside the human body, it's quite scary, right? So how do you treat? Like we can give this amphotericin B deoxycholate, which is a drug of choice for all forms of mucormycosis. Alternative, we can give posaconazole. These are azoles, or isavuconazole. Okay, so next among the opportunistic mycosis, we have this aspergillosis. See, aspergillosis is the invasive and allergic diseases caused by the hyaline mole named Aspergillus. There are nearly 35 pathogenic and allergenic species of Aspergillus, important ones being Fumigatus, Flavus, and Niger. So this Aspergillus can cause invasive, like it can penetrate into the tissues, And allergic can cause allergic manifestation. You have different species, almost like nearly 35 of Aspergillus. Like the most important one we have to remember, Aspergillus fumigatus flavus. Aspergillus flavus is another, and Aspergillus niger. You have to remember this. Okay, so these Aspergillus you can find distributed in nature, mainly in decaying plants and all. And then like transmission is mainly by inhalation. And then risk factors for invasive aspergillosis are glucocorticoid use. Glucocorticoid is nothing but steroid. Okay, this is the most important risk factor. And profound neutropenia, low neutrophil counts. And then sometimes neutrophil count are normal, but there are dysfunction. And then like suppose if you have underlying pneumonia, like if the patient is already having pneumonia due to bacterial infection or COPD or tuberculosis or sarcoidosis, then they are more prone to develop invasive aspergillosis. And then if the patient is under anti-pneumonecrosis factor therapy, they are also more prone to get aspergillosis. So what are the clinical manifestations? Like they can get pulmonary aspergillosis is one of the clinical manifestation. Like they will get allergic bronchopulmonary aspergillosis, severe bronchial asthma, extrinsic allergic alveolitis, aspergilloma, fungal ball. That fungal ball, it will form because of this aspergillosis inside the lungs of the patient. And then acute angio-invasive pulmonary aspergillosis. This angio-invasive, it can invade the pulmonary vessels. Chronic cavitary pulmonary aspergillosis. This chronic cavitary pulmonary, if the infection is long lasting, like without treatment and all, then this aspergillus can form a cavity inside the lungs. So this condition is called chronic cavitary pulmonary aspergillosis. Sometimes it can cause invasive sinusitis. Like we cannot say like sinusitis is mainly caused by bacterial infection and all, or allergic. Sometimes it can be caused by aspergillus species also, like this chronic granulomatous sinusitis, maxillary fungal ball. Like what happened in the lungs, it can also form fungal ball inside the maxilla. This maxilla is a type of sinuses. Okay, paranasal sinuses. And then sometimes allergic fungal sinusitis. And then it can cause, aspergillus can cause cardiac manifestation. We call cardiac aspergillosis, manifested as endocarditis, native or prosthetic. Some native endocarditis is a infection of the inside part of the heart. Suppose this is the heart, the inside part of the heart, the inside lining of the heart is called the endocardium. So if it involves the valve and all, the heart valve, the natural heart valve is called native endocarditis. But sometimes patients used to have abnormal valvular disease, like disease of the heart valve. So they got their valve replaced with a prosthetic one. So if they got replaced with prosthetic one, they are prone to infection. Like aspergillosis is the one. So we can say prosthetic endocarditis. And then pericarditis. Pericarditis is a pericardium, infection of the pericardium. Cerebral aspergillosis. Cerebral, if it affects the brain, sometimes it can cause brain abscess, hemorrhagic infarction, and meningitis. Like brain abscess it may form in the brain, or sometimes like due to bleeding in the brain, it will cause infection, and meningitis, like aspergillus, which affect the meninges. And then other forms of aspergillosis, we have ocular aspergillosis, which will affect the eye, and then the ear also. Ocular aspergillosis is keratitis, like inflammation of the cornea. And then endophthalmitis, and ear infection, otitis externa, like this external auditory canal. Cutaneous aspergillosis, nail bed infection, onychomycosis, and mycotoxicoses. And how to diagnose like specimen, it depends upon the clinical manifestation, maybe sputum or tissue biopsy. And direct examination, we can do KOH mount, 10% of potassium hydroxide mount, KOH mount, or histopathological staining of specimens. They will show narrow septate hyaline hyphae with acute angle branching. This is the difference with that with mucormycosis I've told you before. Mucormycosis is wide hyaline hyphae, and then that branching is wide angle. But in case of aspergillosis, is narrow septate hyaline. Mucormycosis is aseptate without septa, but in aspergillosis septa is there, and then that branching is, in case of mucormycosis, is wide, but in case of aspergillosis is acute. So we can culture in subrod dextrose agar incubated at 25 degrees Celsius. And then species identification is based on microscopic and microscopic mount, appearance of the colonies. The aspergillus will appear like this. This is Niger, I think. This fumigatus, this flavus. These branching are very narrow. These hyphae are very narrow, and they have septa here. And then this branching is at an acute angle. See the appearance of colony, like this one fumigatus is smoky green, velvety to powdery, and then reverse is white, and then flavus is yellow green, and then Niger is black. I'll just show you this one. This is fumigatus, bluish green in color, and then this is flavus, yellowish green, and then this is Niger. Niger is something like black, so you can easily remember Nigeria like that, nah? So this is black Niger, aspergillus Niger. Okay. Other tests for aspergillosis, we can do antigen detection using ELISA, and then antibody detection and detection of metabolites B13-D-glucan or myotal by gas liquid chromatography. So treatment for invasive aspergillosis, we can give voriconazole. For acute bronchopulmonary aspergillosis, we can give itraconazole. And in case of single aspergilloma, sometimes like that fungal ball and all, now we have to remove by surgery. And then chronic pulmonary aspergillosis, like itraconazole and voriconazole. And for prophylaxis, we can give posaconazole. And we have another organism, penicilliosis. This one is penicillium has more than 250 species, most of which are found as saprophytes in the environment. Most of them survive in the environment, and then the most important species is Penicillium marnifae. And then sometimes they produce toxin, this MYCOTOXICOSES, and then this is produced by certain species of Penicillium, like Penicillium cyclopium, Penicillium verrucosum, and Penicillium tuberculum. And then it can cause invasive penicilliosis like endophthalmitis and endocarditis. Endophthalmitis, it affects the eye, and endocarditis, it affects the inside lining of the heart. Superficial disease like otomycosis affects the ear, keratitis affects the cornea, and onychomycosis affecting the nails. Sometimes it can cause allergic diseases like asthma and allergic pneumonitis. So how do we identify this organism, diagnose this? For Penicillium marnifae, it's a dimorphic fungus. Dimorphic fungus is like they can grow as mold and they can grow as yeast also. So other Penicillium they grow only as molds, like at 25 degrees Celsius when we culture at SDA. Colonies, like they have that velvety flat to powdery structure, and greenish in color. They looks like velvet. Every one of you have seen velvet, nah? Sometimes powdery also, like powder, and then they are green in color if you see them in SDA. So if you examine in microscopy, like they are thin septate conidiophore and its branches elongated mutually, flask-shaped phyalites, and change of conidia. These conidia, you have seen change of conidia. These are phyalites. They are flask-shaped, and then this one, the hyphae is thin, septate, and then conidiophore is branching. This conidiophore, and then this conidiophore is branching, and then you have the brush border appearance like that. Brush border, no? See this one, brush border appearance. Can you see everyone?
Yes, sir.
Yes, sir. Yes, sir.
Okay.
Yes, sir.
This Marnifae is a dimorphic fungus. Okay, I told you earlier. So before we used to call us Penicillium Marnifae, but now it has been renamed as Thalaromyces marnifae. It can cause opportunistic infection in HIV infected patients, and then like it's most common in Southeast Asian countries like in India, mainly in Manipur, Vietnam, and Thailand. And then sometimes in rural areas where bamboo rats are prevalent, they are most common. But there's no direct transmission from rat to man to humans. Like risk factors to immunocompromised state is a risk factor. Transmission, like mainly inhalation of the conidia. See, when you inhale these conidia, when these conidia become detached, they spread into the air. When you inhale, you are bound to get this infection caused by Thalaromyces marnifae. And then mold to yeast conversion occurs in the lungs, and then the yeast forms spreads via blood to reticuloendothelial system. Systemic infection, we have like fever, clinical manifestation. It can cause systemic infection like fever, weight loss. Dyspnea is like shortness of breath. Lymphadenopathy, swelling of the lymph nodes. Hepatosplenomegaly, and then enlargement of spleen and liver. Skin lesions, we can have warty lesions mimicking that of molluscum contagiosum. If we see laboratory diagnosis, we can take this tissue section, skin scraping, or blood smear. We can see this oval to elliptical yeast cells with central septation. These oval or elliptical yeast cells, we can see this central septation might be there, but it's not clear here. See dimorphic fungi, you have to there are many dimorphic fungi. These dimorphic fungi, they can be yeast at 37 degrees Celsius. They can occur at two forms: yeast-like colonies at 37 degrees Celsius and mold form at 25 degrees Celsius. So dimorphic fungi, Penicillium marnifae is one of the dimorphic fungi. Okay, mold form, it appears brick red pigment. This brick red pigment is there like the sun shining bright. How you treat penicilliosis? Like in case of AS patient with severe penicilliosis, we can give amphotericin B and maintenance therapy with itraconazole for 12 weeks. And then with mild penicilliosis, we can give itraconazole for 12 weeks. And then we have another one, Pneumocystis pneumonia. Actually, this Pneumocystis pneumonia was thought to be a parasite before, but then it was classified under fungus based on the nucleic acid sequence studies. And then they were renamed from previously they were known as Pneumocystis carini, and then they have been renamed to Pneumocystis jirovecii. And then this Pneumocystis jirovecii can cause Pneumocystis pneumonia. So, like actually they exist in cis and trophozoite forms. In human tissues, both cis and trophozoite forms are found. And then once the cis is inhaled, it is carried to the lungs. They transform to trophozoite stage, and then they induce inflammatory response and recruit. After they induce inflammatory response, plasma cells are recruited, and then this exudate, 40 exudate, they fill the alveoli, and then they can cause plasma cell pneumonia. So diagnosis of this, like we can take lung tissue or fluid obtained by bronchoscopy, bronchial lavage, or open lung biopsy. And then staining method, we have this Gomori methenamine silver staining method, which is the method of choice for Pneumocystis jirovecii. And then the cysts resemble black color, crushed ping pong balls against a green background. See, these are black color crushed ping pong balls against a green background. They appear as this one, appearance of Pneumocystis jirovecii. And then we can diagnose by PCR assay, and then we can detect the 1,3 beta D-glucan in serum also. Treatment, like they are different from treatment of other fungi in terms like because of the cell wall composition. So we can treat them with cotrimoxazole 14 days in non-HIV patients and 21 days in patients with HIV. And then recommended drug for primary and secondary prophylaxis in patients with HIV. Sometimes patients with HIV used to give this drug even if they don't have Pneumocystis jirovecii as a prophylaxis, as prevention of getting infection with Pneumocystis jirovecii. And then we have other one is Fusariosis, like this one you can see in soil and plant found around the world. Like this is the most common cause of keratitis in continence virus and onychomycosis. This can cause infection even in immunocompetent individuals with normal immune status. And individuals with immunocompromised, they can cause angioinvasive and pulmonary and sinus infection. And then it can cause disseminated infection also in some patients with neutropenia and hematologic malignancies. Fusarium, this is Macroponidia chromatopore. We can diagnose this disease by seeing macroscopically by this colony is growing rapidly and is characterized by cottony, flat, spreading white to pink colonies and LPCB mount. They show septate hyphae bearing round microponidia, sickle-shaped large microponidia and chlamydospores. Treatment is with amphotericin B, voriconazole and posaconazole. They are resistant to many antifungal agents. So mycotoxicoses. This is disease caused by production or consumption of food contaminated by toxins liberated by certain fungi. And then mycetism. This is toxic effect produced by eating poisonous fleshy fungi, usually different types of mushrooms. This is quite common in Meghalaya. Some people are eating mushroom which are toxic and which is even fatal, which can cause death. And then different type of mycotoxins. We have aflatoxins. They're produced by Aspergillus flavus, Aspergillus species and Penicillium species. And then like sometimes nuts and maize can have these toxins, and then they can cause like hepatoma, and then hepatitis, Indian childhood cirrhosis, and Ray's syndrome. And other mycotoxin is fumonisins, can cause by Fusarium species. Maize, we can see in maize, equine. It can cause equine leukoencephalomalacia, porcine pulmonary edema, and carcinoma of esophagus. Others are trichotensins, caused by Fusarium, produced by Fusarium species, seen in maize, wheat, sorghum. It can cause alimentary toxic aleukia. It can be used as biological warfare. Yellow rain. Okra toxin, caused by Aspergillus species and Penicillium. It can be seen in cereals, bread. It can cause nephropathies, Balkan endemic nephropathy. Others we have cyclopiazonic acid, produced by Aspergillus species and Penicillium species. Can be seen in groundnut, corn, and then it can cause quadua poisoning, co-contaminant with aflatoxin. And then the other one is Zira linons, produced by Fusarium species Graminearum. It can be seen in wheat and maize. It can cause genital disorders in pigs. Okay then, thank you.
Thank you, sir.
Thank you.
Thank you so much, sir.
Thank you.
Thank you, sir.
Thank you.